Aloha, I am Mark Alexander, Executive Director of the Hawaii Medical Association. It is my pleasure now to call upon the HMA President, Dr. Elizabeth Ignacio, to offer words of welcome. Dr. Ignacio.
Thank you. Well, welcome, aloha, and good evening, everyone. I'm excited that we are welcoming this week AMA to all of our events from Hawaii Medical Association. We have our gala that's going to happen soon, but tonight we'll have conversations with AMA immediate past chair of our Board of Trustees, Dr. Michael Sook. I'll allow Dr. Van Meter to the honor of introducing him and talking about his many accomplishments, but thank you so much for joining us. And let's.
Thank you, Dr. Ignacio. Before our special guest is introduced more formally, allow me to review the format for this evening. We're going to start with a presentation by Dr. Sook for about 30 minutes, after which we'll have an opportunity for questions and answers, a little discussion. For the Q&A part of the program, those participating via Zoom webinar, you are invited to submit questions throughout the program using the Q&A function. Please type in your questions, comments, suggestions, ideas throughout, and we will feature as many as possible after the presentation. For those that are in the room, we ask you to use the index cards, which are located throughout, and to go ahead and give those index cards to the other Mark or to myself, but easier to Mark. And then again, we'll add those to the questions that we will try to feature. The conversation will continue after the formal part as we in this room continue to have a dinner and a little bit of libation. And now it's my pleasure to invite Dr. Jerry Van Meter, the president of the Hawaii Medical Foundation, to introduce our special guest, Dr. Michael Sook.
Thank you very much, Mark. It's truly a joy for me to be able to introduce a fellow orthopedic surgeon of great notoriety. It's really been a pleasure to have met Michael first as a speaker at our orthopedic conference about 5 years ago. He is famous for a long litany of accomplishments, including 4 different degrees, MD, JD, MPH, and MPA. So with a speaker like that, normally you would expect, I'm sure, to have a very articulate person, perhaps a little bit too intellectual for some of us like myself. But I think you'll find him to be engaging, concise, and very down to earth. So I want to welcome Michael Sook. The next time we welcome him, I expect him to be president-elect of AMA.
Thank you, Jerry and Mark and everybody for joining. I recognize that we have a chance to have a conversation today, this is relatively unscripted, and it's kind of my perspective, my opportunity perhaps to give you some perspective of what's happening out in the world of medicine that you all experience even now today. On behalf of the AMA Board of Trustees, I want to say thank you for the invitation for joining today. It's always a great pleasure to come back to Hawaii. Many of you may or may not know that my daughter actually attended high school here at Iolani. She boarded here for 3 years, came right in the middle of the pandemic. And so I recall the time being that without FaceTime, I don't know how we would have survived because that was the only way I knew she was alive during the pandemic. But I had a wonderful experience here. She's now in college in Boston. But the American Medical Association, really depends on so many of you and your participation within the state medical societies. As you know, the association is made up of 189, almost 190 state specialty societies, as well as specialty societies and national medical organizations that really represent what we think is the voice of medicine. Oftentimes there's a criticism when it comes to the AMA that our membership, individual membership, represents probably about 20%, 25% of all physicians in America. So we get a lot of criticism, I think, to that degree to say, well, do you really represent all physicians in America? And the way I counter that is simply this, is that every single medical specialty, every state and every national medical specialty is represented. And as a result, over 95% of physicians are represented through something. If you're a specialist, if you're a family physician, if you're doing something in radiology or interventional radiology, your voice is represented through your societies. And our annual and our interim meetings are really critical to that fact. And because of that, not only do we represent all of the state societies, but we represent virtually every life stage within medicine. And that extends, from medical student the day you start and the perspective that you bring in, all the way through to the time you retire, and senior physicians who are still part of the association have their voices represented. In addition to the life stages, it's every particular practice setting. And so increasingly now we see more physicians today being part of larger employed groups. And so we have a new integrated practice section that represents the employed physician, which is a significant voice today, different than it was almost less than 20 years ago. And I think what we're finding now is that physicians' interests, while all being common and the same, I think are reflected differently in their different practice environments. I would just say, as an employed physician myself for almost all of my career, it was difficult, I think, to really get a tangible sense of kind of what's happening in the reimbursement. I have a back office in a large organization that's doing it for me, to really understand the impacts of the changes that are happening at the federal level. And so now that we have those perspectives that are all coming together, I think it gives us a much more comprehensive view of how we can approach these from an advocacy standpoint, from an education standpoint, and other aspects in which we can have influence. I think that some of the issues that are probably prevalent and top of mind for everybody is obviously one of the main issues for us is this idea of Medicare reimbursement, and the fact that every single year we continue to take a cut. We recognize that every other sector within healthcare continues to rise with the rate of inflation, but in the last 20 years, physician payment has stayed essentially flat. I like to say that essentially 20 years in, or 20-something years into practice, I'm getting paid less today from a Medicare reimbursement standpoint than I would have as a resident. And these are significant issues that continue to be resonating. I think it's a commonality among all physicians in practice that we need to fix this. We continue to fight very hard for that. I think physicians today continue to face huge issues with prior authorization. I know the recent lawsuit within the state of Hawaii, which is recently adjudicated, attacked this head on, and the prior authorization policies that are arbitrarily placed can have significant harm and detriment to patients. As a result of, I think, the wisdom of the Supreme Court is there are certain things that need to be that we need to make sure that are not rote decisions, but are something that need to be adjudicated on a case-by-case basis. Recognizing that prior authorization is something that's going to increase. Many of you are aware of some of the changes that Cigna and other organizations have started to place just as an automatic prior authorization requirement. And we also know that from our surveys that when you have a prior authorization that is put into place, if you actually go through the process of appeal, you're going to win about 90% of the time. The problem is, and we recognize this, is that nobody pays for prior authorization, right? So it's an unfunded mandate by an insurance company to come in and say, you have to go through these hoops. But going through the administrative hoops to appeal it is actually on the burden of the physician and physician practice. So recognizing this, it's an interesting conversation to have of how we might be able to put that script and address that. Other issues that I think are really important is the question of market consolidation, what's happening. We look at market consolidation in a lot of different ways. Number one is we see the insurance companies are getting fewer and fewer. There used to be at one point in time, we had a lot of regional health plans. Today, you've got conglomerations of very large national health plans that are across the United States. The second area of consolidation that occurs are hospitals and mergers. Used to be that you had local community hospitals. They're now part of larger networks. And the other consolidation, we're seeing what's happening in the employed physician market. Today, we know that almost 75% of physicians are in some sort of employed arrangement. These are concerning trends that occur, but I think it's the way healthcare is moving and the AMA needs to be ahead of the conversation to be able to see where that puck is going to be at the end of the day. So when we look at these trends of consolidation, we have to ask the questions. The promise of consolidation is that they were going to deliver cheaper, less expensive, higher quality care. And what we know based on the studies that we say is that's not necessarily true. This idea of big medicine hasn't necessarily proven the fact that they're doing it for less expensive and higher quality. And so it begins the question is it too late to intervene at this point? Or is it too late to bring balance back into the equation? I think with the help of HMA and physicians who are in practice, we need to continue to articulate some of that conversation. Other issues that I think are really at top of mind for all of us, this is probably the elephant in the room, is this idea of healthcare and AI, right? The radiologist in the room 10 years ago, I had a conversation about AI very early on, and I said, I was actually at an ACR meeting, and I actually said, half of you won't have a job. This was 10 years ago. They threw me out of the room. But at the point, this was at the point of promise where this idea that something would come in and review 10 billion chest x-rays and be able to identify certain things. So the diagnostic radiology would ultimately be given up to, a large language model that will review us. I don't know, what the truth is behind that, but I can tell you that with the pace of change, I have great concerns for certain areas, like diagnostic radiology, pathology, other things that are really based on the idea that you can do a large sum of images and compare them on a scale of billions. Seems to me that is a future that is probably fairly imminent. I hate to say it, Jerry, thank you. I hate to say this and maybe rub it in. I don't think the orthopedic surgeons are going to be replaced anytime soon. Cognitively, maybe, but procedurally, I don't think the robots are ready for us just yet. At least I hope that's the impression that I hope will stay. But I think that some of the things that are happening in AI today is a little frightening in the sense that it's happening at such a rapid pace that it's very difficult to know where the direction of who's going to be in charge. So where the AMA fits into the larger debate of AI is not necessarily to fit into the technical component of how they do things, but it's more so to continue to push the argument that this is not artificial intelligence, it's augmented intelligence. So the reason we use that term is so that physicians can remain at the center of how we use these new technologies. The other areas that I think people don't necessarily recognize is that we also bring an ethical and regulatory framework around AI, in the sense that we know that there are problems with large language models, in the sense that all the data that goes in is based on certain data sets that exist. And we know that those data sets at some point are really biased, are inherently biased in some ways. And then most of the studies that are done for large chronic disease studies are largely done on populations that aren't necessarily reflective of the islands in Hawaii, as an example. And so we know that those treatment recommendations, those large databases, I think also introduce a certain element that have to be recognized. I think the other part too is who's regulating, this whole idea of AI. Who's to say that what is being used is appropriate? And placing the physicians at the front of this, I think, is a really centerpiece of what we're doing at the AMA. And we just launched, many of you may have seen recently that we have a recent announcement that that the AMA is creating a new center for digital health and artificial or augmented intelligence. And what that purpose is to put the physicians at the center once again. I've taken a lot of interest in this particular area for some time. And I've attended certain conferences where they have these great software developers, these new programs. So one of the biggest is health, HLTH, PIMS. And I remember going to my first one several years ago, and you walk on the floor with a badge that says MD, and it's like flies to flypaper. I mean, you've got all these companies that want to come to you because they're like, I've got to show you something. Can you tell me if it'll work? Right? So the disconnect between those who are creating a solution to what they think is the answer and those who are at the front line to say whether or not it's going to be helpful, I think creates a huge opportunity for us to be able to put physicians again at the center. Wouldn't it be great if companies out there were able to come to a central location and say, I've got this idea, can you connect me with physicians you might know? And I think the AMA has a really strong potential place in doing so. I think that covers the world of AI pretty well. And I would just leave you with this concept, and it's applicable to a lot of the things we've talked about, is, for those who are skeptical of what the AMA does, what the AMA, stands for, every one of us, I think across the board, even in this room and probably in the audience, will be able to find one or two things, or maybe 10 or 20 things that they agree and disagree with. In the aggregate, however, the association stands for what it is to be. And I think that one of the key components of that conversation is that we're never going to agree on everything. But I would just argue that it's not it's not a good idea to toss out the baby with the bathwater in the sense of saying, if I disagree with this particular stance, I can't be a member of that organization, because then you're at the end of the day, the only organization you're going to join are the ones that you can look at in the mirror. And I think that I think doesn't help us a great deal as an organization. Physicians need to bond together more now than I think ever. And I think that the critical aspect of that is that when we are faced with a number of different challenges that society brings to us, particularly within the healthcare environment, the best thing for us to do is to bind together based on the very central theme of why we became physicians, to help patients in the first place, to do what we can in order to facilitate that patient, that really sacred patient-physician relationship. You know, as reflected in the Supreme Court case that we just talked about, it's the idea of standing for, you know, what is best for the patient and fighting against all the elements that want to encroach upon that. Those are some of the elements that I think are critical to what David is. I'm going to leave it at that, Mark. I know we had a half an hour to kind of spend, but I'm happy to take questions. You know, if there's people in the audience who want to hammer one of those issues that they really hate the AMA about, I'm happy to talk about that as well. But as you know, I won't shy away from any controversy. I'm happy to jump through. Thank you.
No, thank you very much, Dr. Soot. You're a great speaker and you're very engaging. I think a lot of us are looking forward to the comments that you might make. Let's jump in on a few things that have come, you know, our way already. But before getting into some of the specific questions, one general one is the impact of the federal shutdown on healthcare.
Sure.
And, you know, I know it's impacted, you know, telehealth, for example, hospital reimbursement, all kinds of areas. Have some comment on that.
It's interesting. You know, the question of the shutdown really centers around healthcare, right? And so, you know, the items and the issues that we're very directly involved in has basically shut down the entire country from a federal standpoint. The center core issue with regard to that, as many of us know, is that it centers around the extension of the ACA subsidies and the potential effect on the population from their ability to get insurance. You know, we can pick a side in terms of whose tactics are correct in terms of this. But at the end of the day, I think what we're looking at one side that says that we want to eliminate fraud, waste, and abuse. And that's what they say. And the other side that says we can't eliminate what we've already given. I don't know what the answer is at the end of the day, but its devastating effect is significant. I'm lucky that I made it on time on the flight yesterday, because I'm worried the air traffic controllers are going to be out of job, right? And I think some of the concerns with the larger shutdown is that the selectivity in which they want to say, well, these are the people who are going to get paid, these people are not. But when it comes to healthcare, we're looking at a significant change that's about to happen with regard to the number of people who are currently covered. You know, whether or not we believe in work requirements, whether or not we believe in this idea that you want to make sure, or at least what the Republicans say, you want to make sure that healthcare goes to the people who deserve it, illegals, whatever the conversation is. Regardless of what happens, there are going to be people who are going to be affected. And we're going to see a significant decrease in the number of people who are eligible for care. What that ultimately results in, too, is the fact that many of our states are dependent in Medicaid on provider taxes that come through that help subsidize the remainder of the health system. If you can't provide care on the front end through a population lens, chronic disease prevention, preventive visits, then you're going to see an overwhelming number going to emergency for acute care. I think that this is one of the major issues that we're going to be facing. My hope is that we'll find a way to at least, if they can pass the continuing resolution, to be able to get some funding to move this along so we can have a real debate and they can hammer out their problems later. I just think the shutdown, seems to be a drastic stance that there's actually no action that I can see that's happening. There's no conversation happening. It's just we're 3 weeks in. People are just sitting around saying, okay, that's where it is. Nobody's talking to each other. I think that's significant.
So you're much closer to things than we are. What's your sense in DC? Are we going to get any traction in the next couple of weeks, or?
This particular, it's amazing. We're 10 months into a presidency, and it feels like it's 15 years. Right? I mean, there's so much that has occurred. Every time you turn around, there's something new, and every time you try to address that something new, something else happens. Right, so it's very difficult, I think, to be able to focus anybody's attention on the issues that come up on a day-to-day basis. So to your question, are we going to get tracked? Are something going to happen? It's a difficult question to answer because you've got one particular political party that is really has swept the entire, essentially all three branches. And while I think the prevailing wisdom is that compromise is good, at this point in time, one side doesn't think they have to compromise. I think the tactics that are happening is what has ultimately led to where we are in terms of shutdown. My sense is that things are going to start to get acute fairly quickly. When you're 6 weeks, 8 weeks without a paycheck, something's going to have to change. I think that it's very interesting to watch the general media today in that, for all of us, I think it behooves us to watch multiple channels to get the truth, right? Because you don't know what is actually the truth out there. And some will focus a lot on what's happening with immigration, and it's the high focus, and others will sit there and talk about, immigration from the entire other side. And then somewhere weaved in there is the shutdown, right? And, it's tear gas here, tear gas there, and then air traffic controllers, by the way, they're not getting paid. And you're like, I don't know what the hell is happening. So, but at the end, so when we see all of this in the mix, for physicians for all of us as physicians, we know that healthcare is the driving, source. It's a huge part of our GDP. It's going to be a continuing source of debate in terms of how we provide the care and how we are ultimately, going to fulfill our missions.
Well, switch gears. I'm going to be jumping around, and I'm going to do my best to read the handwriting because how physicians are known for their fine script. A congressman from Louisiana introduced the Pharmacy Benefit Management PBM Reform Act. What are the hopes for PBM reform on a national level?
PBM reform is very interesting. So, from my perspective, the one person that's driving the debate more than anybody is Mark Cuban, right? And this is the person who's coming in from the private sector to recognize that the pharmacy benefit manager, which is the middle person between the patient and the pharmaceutical industry, is really a money mill. And it just, it sets rates, it does all these things. And Mark Cuban coming in from the private sector and saying, we're going to eliminate all that and go direct with consumer, I think has really changed the debate. Is there hope for reform? I think so, right? And from a federal level, there's a couple things. One is the PBM legislation that's potentially coming. I think the Trump administration has come out very strongly in terms of favored nation pricing on pharmaceuticals, right? Which is an interesting concept. The GLP one, I was reading this just the other day, is cost GLP-1 for a month's supply will cost you $113 in the UK, and it's $1,300 in the United States, right? 70% of all of the profits for pharmaceutical companies comes from the United States. Because almost favored nation pricing across the world is significantly discounted because the governments are negotiating those prices. So when President Trump turns around and says, well, we've got to make this fair and balanced, pharmaceutical companies come out and say, well, we can't innovate because we depend on those dollars to do research and innovation. But all of those dollars tend to be tilted coming from one country. Now, I don't know what the answer is, but he's done this multiple times. It's a consistent debate, a consistent concept that he has when he says, if you look at foreign affairs, he says, look at the United Nations. We're funding the bill. Why isn't anyone stepping up and paying the bill? Well, look what happened. He put that out there. Everyone thought he was crazy. But now Spain, everyone's putting their GDP on the table. Again, the rhetoric and the brimstone that comes along with it is difficult to absorb. But at the end of the day, it raises an important issue. I don't know how that's going to go, but you take those two things in combination, you're going to see potentially some significant changes in the way we pay for pharmaceuticals and the way that they're priced in the United States for it to be much more accessible. We haven't even talked about GLPs. That's already changing the world.
Regarding centralization of the healthcare industry and vertical alignment, what effects can be made to spin these services back into physician practices? For example, adult immunizations in the primary care office.
Another, so, it's just a small topic of immunizations in the country. I'm going to harken back to a couple things. One is, the immunization issue has really not only raised its head, but it's also revealed the number of downstream effects. So on the obvious one is when we talk about immunizations, and you raise the specter that it has side effects that we've been ignoring, and that the result of pushing immunizations or vaccines for children becomes a patient choice and not something that's good for public health. The downstream effect of this, and we've already seen this, is impact in terms of the rise of the cases of measles, kids are dying, things like that. The separation that's occurred in terms of taking what's your typical MMR and now saying every parent has a choice to get one. It's now 3 shots per child rather than 1 combined vaccine is another issue that's going to come down the pike. Then you add to that not only the question, but the disruption and the dismantling of a federal body, right, that was made up of experts on the immunization, the Committee on Immunization Practices. Complete dismantling of that, which were supported by our specialist societies to elevate experts into those roles, to a now new, different body that was appointed by the Secretary of Health, focused on perhaps issues that were related to some of the issues that he was concerned about vaccines, now creating a separate set of recommendations. So what's now happened is we're looking at from a public health standpoint, and now we don't know what to do. Right? On the one hand, ACIP, the Committee on Immunization Practices, made recommendations for vaccines for adults and children, said these are the ones that we think are necessary. These are the ones we recommend. And now you have prior to May, a set of ACIP recommendations, and then after May, you've got a set of alternate recommendations. So there's a coalition of states and national medical societies that are now saying, let's stick with the pre-May schedule and empowering physicians to at least have some evidence base that says this is the way we recommend it should be, versus now what the federal body is doing. This sets up a very difficult situation because of 2 things in my view. Number one, it's not necessary. It's not harmonizing for us to be able to have a private group and a federal government sit there and say we don't agree on what we should do on public health and vaccines. But the problem that I see coming down the pike is the one that has access to all the data is the federal government. And so the battle may be short-lived at this point, but the future status I think is going to go because they have all of the data, the vaccine data that's coming down the pike. It's a short-term battle now, but I think the long-term consequences are very significant. There's no way for private groups or coalitions of private groups to be able to coalesce and collect all the same data the federal government. And so that's where I see the future potential problem coming. For the practicing physician, I think it ultimately comes down to the thing we always talk about. It's a conversation between the patient and the physician. And I feel badly in the sense that now pediatricians, family physicians are now having conversations with patients, parents to say whether a vaccine is even useful, right? And I think that's an extraordinarily unfortunate circumstance at this point, particularly when you're seeing things like the epidemic that there, or the spike in measles in Texas. I think you saw 3 or 4 weeks ago, the Secretary of Health of Florida basically said we don't require vaccines anymore in children. And he couched it as a conversation, as a patient choice issue. And the medical community is talking about it from a public health perspective. And it sets up a really, really interesting philosophical debate that should be taken outside of actually real impact, right? And said, what is patient choice? What's the public health concern? And how do those 2 mix? And that's setting up the debate as we speak.
Well, let me push you a little bit
Sure.
on 2 things. First of all, that one, in terms of how do you resolve that? What's the solution strategy to come to some kind of consensus, or is that just not going to be possible for a while?
I think our governmental structure makes it really challenging to find a very straightforward solution, because by statute, the Secretary of Health has the ability to appoint that committee. That's just the way it is. Now, from a governmental standpoint, is there a way to create a federal legislative process to bypass that? Probably, but look at our legislature, right? Getting something like that in a consensus in Congress today, I don't think would do anything to upturn what the Secretary is. And so I think part of because of the politics, as they said, in this particular time before the midterms, makes it really difficult for groups to be able to create a national movement outside of these coalitions, and we're trying to preserve the pre-May recommendations of that. The other issue is pharmaceutical companies, if they start focusing on decoupling, the MMR vaccine into 3 separates, that's going to make the problem worse. I think down the road. The accusations that fly, I think, are with regard to physician. You saw many of you may have seen Bobby Kennedy has accused all pediatricians of being on the take of the pharmaceutical companies, right? And this is an exaggeration, I think, of the fact that when pediatricians buy vaccines to hold in their offices, right, they're doing so for the purpose of ease, efficiency, and giving medications to patients. It's not because the pharmaceutical company paid them to hold them and start giving them the offices. So I think there's truth to all of these. There's truth within all the nonsense. But again, who's going to speak up for all the physicians other than groups like the state societies and the AMA to continue to fight this?
Which underscores, your primary thesis. Physicians really have to come together more than ever.
Yeah, I think, and again, I think it's an important platitude, maybe more than a platitude, for us to say that docs have to stick together. The problem is that when we have this plethora of issues that we all face, we fall apart very quickly, right? If you're on the surgical side versus the non-surgical side, the debate becomes, why are procedures paid more than time-based visits? Because we get forced into this octagon of infighting that says we have to have a budget, right, that is limited for all of medicine. So if somebody comes and says, I want more time, more money for pediatricians, it's not like there's a magic pot of money. There is, I'm going to take it from the radiologist, from the orthopedic surgeon, and we tend to circle the wagons and fight with each other. Nobody's more happy than this than people who want to dismantle medicine, right? And we talked a little bit about consolidation, and we talked about all the groups that are getting larger and larger. And physicians, even though we're in short supply, have a harder time sticking together to create a large movement. At the AMA, we try to do this all the time, but I'll just give you some off the cuff examples. Whenever we post something, we're getting more active on social media and things like that. But whenever we post it, just look at the comments. There's a Yahoo everywhere that sits there and say, oh, I quit the AMA 35 years ago because they did something terrible. Or I don't believe in this, or they don't represent me. And it's just the trolling that occurs. And you just wish people would just stop for a second and say, if we weren't here, then who? There's a wishful thinking in a lot of this criticism. It talks about, we don't want the AMA, we want something else. Well, I'm happy to do something else if you show me something, right? But I think if we stopped and asked the question, if not the AMA, if the AMA was not here, then who would do it? And Bobby McCumla, our current president, has pushed this message. I think sometimes to kind of some criticism is the fact that at the end of the day, what we do, or the practice of medicine, benefits everyone, whether you're a member or not, right? So trolling the AMA and saying, I'm not a member, that's great. He, came out very strongly and said, then you're freeloading on what we do. He got into a lot of trouble for that. But at the end of the day, there's truth in this. Is that if you can't stand up and you just want to criticize, then just take the benefit.
No, I mean, we make the same argument here with Hawaii Medical Association. We're the lead on the bill that brought general excise tax relief. They've been working on it for decades. We're the lead, and on every level, but the people that benefit from it are members and non-members.
Yeah.
Our leadership thinks it's very important that we do the right thing for the right reasons in the right way. But, like you say, people do freeload. But I think your message about hanging together is so important.
Yeah. I think, we're all bound by the same reason why we went to medical school. Right? I mean, if you look at the substrate of first-year medical students, right, they're all bound together. They all see each other as medical students. We somehow change when we graduate. Right? We go into our specialties, and we stay in touch with classmates at alumni reunions. But at the end of the day, the day you start, I remember the first day I started medical school. I couldn't wait to join the AMA because I wanted to get my JAMA. I don't know what the hell I was reading, but I wanted to feel like I was actually part of the community. So I get my JAMA, I read the first article, like, I don't know what they're talking about. But I felt at that point that I was joining, a sacred profession. That's why it's so important to get medical students involved at the early end, is that's why we're here. I have a niece that just got into medical school this year, and I bought her a 4-year membership. She was like, why? I was like, just do it, right? Because you need to understand what you're taking. I think that part of the evangelism that I do across the country is I try to speak to the specialties in other states. States are a little bit easier than we're a federation and our members. Specialties are difficult because a lot of specialties have their own advocacy, they have their own thing. But at the end of the day, I would say that 90%, 90+% of all specialty advocacy work is exactly aligned with what the AMA is doing, right? And so when you have that, then why aren't we much more powerful in Washington? The AMA is still a very powerful voice, but every specialty wants to have their own lobbying day, right? And so when we go to Washington, for a national advocacy conference every February, we go in and the AMA comes in, but then 2 weeks before the anesthesiologists are there and the orthopedic surgeons are there a couple weeks later, and they're like, again, why are you guys here again? And they're all with the same talking points. It's one of my dreams to see a day when 10,000 physicians show up. I don't know what it's going to take to get us that fed up that we show up. But at some point, 10,000 physicians walking in Washington on the same day, pretty significant thing. And sadly, I think that our environment continues to push us in a direction where I think physicians are starting to understand that their autonomy, their independence, their ability to think creatively, the incursions on what they do, higher levels of burnout, more commoditization of what we do. If you want to pursue excellence in your specialty, there's a perception that you can be replaced by anybody, right? And I think these are some of the things that I think are increasingly frustrating for physicians today. I temper that with another observation that for those of us who have been practicing a couple of decades, the generational character of people who are going to medicine is very different today too. They're growing up significantly with AI as a major. There's a phenomenon called open evidence. Maybe they use open evidence. They just got $200 million investment. They have a market cap now of several billions of dollars. What this is the Chat GPT for medicine, right? I studied pretty hard in medical school, man. I wish I had this thing, but it has significant implications on the workforce, which is another issue, right? So, there's this concept that, in certain areas, there's been this push on scope of practice where they think in certain rural areas that a physician assistant and nurse practitioner have some independence to be able to do that because physicians are very hard to get to practice. Interestingly, when you add AI to the equation, it becomes a very interesting question. Do you need a physician or can you have a PA or nurse practitioner with AI? Right? And then it leads to lots of other things in the rabbit hole. Well, who's responsible? What's the liability situation? Who's going to supervise or who's going to be independent? Where are we going to, when the first mistake happens, where's that going? Right? But this question of AI really augmenting what we do is a very important question. And I think our future workforce for medical students are grappling with this now. There was a point in time when, my kids, and I've seen other kids, I don't think anyone has a textbook anymore, right? It used to be you had to study a book, right? Now you listen to a lecture and it summarizes it for you and gives you flashcards.
We have several medical students in the audience.
Right, guys, am I wrong? Right. But I would love that, but I feel like I got duped. There's a better way to learn. But at the end of the day, again, all of that I think plays a role in what the future physician work. It's going to be so much more augmented. I think there's hope that there will be lots more integration, lots more cross collaboration, because I think it'll be easy. I think that administratively, many of you may have seen this is a positive side. I'm going to talk a lot about this on Saturday too. I think I'm just off the top of my head, but one of the things that I think is a positive sense of equation, many of you have seen the chart where the number of physicians has gone up slowly. The number of administrators has gone up like 15,000%, right? Many of us attribute that to, the Affordable Care Act. Obama said we have to implement EMR. Physicians aren't trained for any of this stuff, so let's bring in some people. I mean, the administrators, people get an MHA, and these 20-year-olds are running hospitals and hospital systems, right? I think, again, this is the hopeful part of AI. So much of that administrative work, I think is going to go away, right? I mean, think about, already we're seeing, the changes in prioritization. There's an app for that, right? One of the funniest things I've ever seen was, they're applying AI to implement prioritization. And now there are programs that are fighting prioritization. So it's AI versus AI, right? It's like boom, 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 and you just look going on in the back. What the hell is happening? I don't know what's happening. And then the other parts of just the administrators. So as a surgeon, we see in most hospitals, if there are surgeons in the room, that ORs don't run very efficient. So we did layer administrators on top to see if they could handle it, make it run better. For my entire career, I've always scratched my head. Why does an OR start late? It's 2025, right? I mean, how many industries would tolerate that? You got NVIDIA, you got all these companies, but yet the human resource element of what we do in every hospital, I guarantee you, every hospital I've ever spoken to, every surgeon I've ever spoken to has exactly the same problem, right? Nurse, the patient didn't come down from the floor on time. They couldn't get an IV. The anesthesiologist didn't get there on time. It goes on and on. It's the same equation. I can't figure out for the life of me why that's still an issue. And my hope is that that's going to change. So the hopeful portion of AI is that my hope is that it'll create incredibly more opportunities for efficiency, which will decrease the HR component that's driving costs crazy, and that it will allow physicians to do exactly what they do. That's my hope with AI. Medical students who are going through it, that's my challenge to you guys to figure that out, right? Because the old guys like us, we're hopeless.
You dropped another bombshell, which I at least have to ask you to comment on a little bit further, and that is, with all the data sets being really held at the federal level,
yeah.
And at local levels, or specialty levels, there's no way they're ever going to be able to create a comparable data set. But we need that larger data set.
Yeah.
How do we navigate that divide again?
Again, it's very difficult because, when you look at in the vaccine world, or if you look at anything from a federal standpoint, the data comes through the CDC, the NIH, and other bodies that are there. And that's just been the traditional repository. There's no private body holding all these things. The way we navigate it is to try to continue to press the issue to make sure that people understand that there have to be multiple views on the data going through. Where the danger is, of course, is that it's an established pathway, and that again, I think the longer term is more of a problem, right? 10 years from now, we have no access to that, and we're operating on data from 10 years ago, right? And it's not contemporary, and I think that's where the focus starts to see.
Are there international models that can help us?
It is. I'm not as familiar, particularly in the vaccine. My sense has always been is that the world takes its cues from us.
Mm-hmm.
Right. I don't know of any, again, I'm not specific as an orthopedic surgeon, I'm not really specific, but I don't necessarily think that the UK or the Swedish vaccine schedule was any different than ours pre-May. And I think it's because we had really led the charge. Now, at some point in time, would we want to accept the Swedish registry and say that's the recommendations we want in the United States and ignore our own data? I don't know. I hope that doesn't happen. I hope we're going to be able to find a way to get past it.
Well, we use this as the nexus to another international question. In Hawaii and elsewhere, the discussion around how to integrate and welcome internationally trained physicians, keeps coming up, and we have some legislation to address that, to make that a little bit easier for all the new visa requirements and costs that are attendant to that. Do you have any comments that you'd like to make, or AMA is?
Yeah, I mean, I think the J1 conversation has really upended a lot of things for the United States. I think, its purpose and intent wasn't directed at healthcare. really a brain drain or things are happening in the tech industry, but the consequence is a ripple effect on physicians, right? So 23, 24, well, upwards of 25% of physicians in this country are foreign trained. So a quarter of our care in the United States is delivered by physicians who are trained in an international setting. The J1 visa opportunity is a pathway for international medical graduates to continue to practice in the States. Imagine, with this $100,000, fee that's being associated now with the J1, if you're Meta or Google and what, listen, I don't feel badly for them, right? If they're going to pay it, but if you are a critical access hospital in, rural Lanai, and you want to hire one physician on J1 because you can't attract somebody who graduated from U.S. medical school, and your budget is $100,000, right? Being faced with the tax to hire one physician to deliver care at $100,000 is a significant hit. But you can't run a hospital with one physician. You bring 10. Now you're spending $1 million, right, for 10 physicians to help run a rural location. That to me is an extreme burden for anybody. And even if you're a large health system, nobody runs on a margin where they got $1 million to spend. So what's our advocacy on this? It's clearly, as it was written, it says it's $100,000 per J1 unless there's an exception. And so while we love our colleagues in tech and all that, we're going straight for the exception. Them is pushing very hard. There has to be a very carve out for physicians in this area. I think knock on wood, I think we're going to be successful because the numbers just, don't lie. We're not Meta. We're not Google. Hospitals don't run like this. Even the largest healthcare systems don't run on margins that leave them with billions of dollars to spend on. And so, and recognizing that, so much of this country's care is given by physicians of international origin. And then coupled with the fact that we're facing a significant shortage of physicians. When you look at shortage, you have to think about it in two ways. How do we get more physicians in the pipeline? How do we generate more residency spots? And then at the same time, we fight the battle of how do we limit scope of practice? Because it's easy to say where there's no physicians, bring somebody else who's not a physician to deliver what they would argue is equal care. And we all know that, physicians are not there to do 80% of the routine. We're there to recognize the 20% that's not routine, right? I think people don't recognize when they talk about, non-physician practitioners coming in to do what a physician does, they're focused on the 80%. But we know as physicians that we do the 80% and we recognize the issues with the 20%. And when you're missing the 20%, then you got a big problem. I think, there's a lot of litigation around the country that's kind of demonstrated this. People who are not adequately trained or people who are, who are not trained as physicians, delivering care and delivering care for them. I think has started to bring this up more to light.
So another element of the foreign physician issue is new pathways to get them integrated into the medical system.
Yeah,
making that easier for them.
So it's interesting. There's a couple of states. I think Tennessee was the first that began to say that you don't have to do a U.S. residency or practice. They put some limitations on it, focusing on the rural areas, putting a time frame around it. You have to practice in this area for 5 whatever years, but you can come through a pathway as a foreign physician to deliver care. I think other states, I think North Carolina is another one that's beginning to do that too. This is an issue that's a state-based kind of controversy or a conversation that has to take place. And, it has to do to some degree on, there's a quality issue that needs to be addressed head on. I think the world is different today than it was maybe 20 years ago. I think the standards of education for medicine are fairly global at this point. I think that the Flexner and the way the U.S. Healthcare system is structured is that it creates a sense of rigidity across global. If you go to school in Korea or if you go to school in India, you're going through your 2 years basic science, going through your 2 years of clinical work and things like that. So it's not like you're an MD graduating from a country and you just 6 months of school. So I think that has changed, I think, our perception of the quality work that physicians of other countries are doing. And that, I think, has helped bolster this conversation around changing the requirements.
Where do you think AMA is going on this issue? Because right now they've been a little bit.
I think the AMA is going to go where the House of Delegates go. So I would say that the reason why we have a House of Delegates is because it, again, represents the voice of 90+% of this country. I have a strong suspicion that this will be a very robust debate in our House of Delegates that'll help shape kind of.
Even this fall already in interim meeting?
I haven't seen it this fall, but it's certainly a question that's going to.
For the future.
I think so.
Thank you. Let me do it online. Did the AMA have a pro or con position on RFK? It's pick as Secretary of HHS.
I think the AMA as a organization made up of lots of individuals and societies have many positions in RFK. As far as an official position on his nomination, we did not take an official position. And a lot of that was, I think because at the time of his nomination, we only knew a small portion of what his position. His anti-vaccine position, we had strong policies on vaccines. But on the issues of prevention, on nutrition, on physical activity, on the lifestyle aspects, we also had strong positions in support. And so as a result, as he came through as a nominee, our stance was to not take an official position. A lot of people are upset with that. A lot of people were not necessarily, too upset with that. And so the world and the politics as they are, I think it was a divisive issue. That's
Well, as you say, probably reflects where the House is.
Yeah.
The other question that comes in is, can you comment on the success and the failed attempts on, I believe this is remodeling the business of health, ACOs, value-based care? Where do you think healthcare needs to go in regards to these kinds of things?
The value-based care conversation is over a decade old now, right? And it started with the Michael Porter conversation, which basically said that value in healthcare should be driven by outcome and cost. And then we started adding all these other things. But the original equation for value-based care is that you want to increase outcomes and also at the same time by decreasing cost of care. This was kind of a hybridization of what originally came out as the triple aim, right, out of IHI. And then all of a sudden became the quadruple aim, and now it's the quintuple aim, and it's the sextuple aim. We keep adding things. So value became, not only costs and outcomes, but also became patient experience, became additive things like, quality, aspects of quality. And the conversation has gone on significantly. And it's driven a lot of what I think systems have begun to do to try to drive care upstream, right? Recognizing that chronic disease, if prevented, if it can prevent an acute episode, it's far less expensive, far more impactful for someone's long life than it is to do an acute episode. So an orthopedic example is if I address diabetes early, we recognize a pre-diabetic and address them by treating them with nutrition, activity, and other interventions at a cost of managing their pre-diabetes. It's far cheaper than addressing their amputation because they had their foot ulcer because of later. Okay? That's the theory, and that's the problem that I see is that we haven't changed our financial system in healthcare significantly enough to make that hugely impactful. So ACOs emerge as a result of this kind of interplay between prevention, try to manage the care earlier, prevent acute exacerbation of the disease. And they did so with certain incentives to try to manage this population. I think they've been, to a high degree, somewhat successful, but I don't think it's moved the needle. I would say that about 10% of our payment structure today is based on the value-based care arrangement, but 90% of what we do is still acute episodic. And so as a result, I still think it's an important objective to get to. I think we're still a long way to get a lot of buy-in to. And so one specific example of orthopedics, we created these bundles. We said that we're going to bundle care because we think an episode can be managed better if we look at one price for all the things, all the soup to nuts, 3 days before, 90 days after an orthopedic episode. We're going to give you one price. Manage the post-op rehab, manage the prehab, manage the acute episode, supply chain. We did a great job of driving that cost down. The problem is that once you've driven the cost down, it's been a race to the bottom. There's no more to get out of it. So we recognized early on that maybe patients shouldn't go to an acute rehab hospital because it's very expensive post-op. We started pushing patients to go home with equally high quality results. We cut a big chunk of expenditure right there, and we saved a lot of money. But is that true value-based care? I think it's just a different way to manage acute episodic care. And because we haven't necessarily done in this particular example joint replacement, we haven't solved the problem of arthritis. Right? People are still gonna, I rue the day that I'm worried about the day that we come up with a pill to solve arthritis because I'm not a job. But at the end of the day, I just don't see that happening because it's a problem. So again, I'm cautious. I get into trouble when I say this. I'm cautious about, looking back at our 10 plus years of value-based care movement and really starting to ask the question, how far have we come? When we talk about things like spine surgery, there's a recent report out of the Mount Institute that says that, like 50% of all spine surgeries in the country are unnecessary, right? That's until you talk to the person who actually got better, right? Where they thought it was absolutely necessary. So you can put these things out there. And then, the value-based care conversation becomes, well, how many surgeries of that, how can we identify the 50% and not do surgery? Well, I don't know. I mean, it's a big number. I don't know which of the 50% and, who have low back pain will benefit from all. So I think we're moving the conversation probably far faster than we're showing right now. Again, that's a little bit heretical for me to say, and I'm sure I'm going to get a lot of hate mail for that kind of thing. But I still think it's a worthy cause. I just think we're still very slow to get.
Well, to continue the hate mail
Thank you.
opportunity,
Yes.
I want to bring up a topic that we touched on a couple of years ago when we last had our conversation on the podcast, and that is unionization.
Yeah.
Because the latest data that I've seen indicates around 9% of physicians now belong to unions, obviously, residents and younger physicians compared to 10 years ago when it was closer to 5%. So comments on that?
Yeah, I again, speaking generally is, if you go to the reasons why physicians or people unionize, right? Unions occur, if you look in history, because workers were badly treated, right? That's basically how it happens. When workers are badly treated and they look at their neighbor and say, you're a worker and you're badly treated too, we should do something about this. And then you find, and they feel if there's no outlet for their ability to change, then they're forced into a bucket to create something called collective action. So that's how I think unions arise. So take that general philosophy and apply it into the physician workforce. What we've seen is that the rise of unionization, as you rightly point out, has really occurred among the residents. And that to me points out a couple things. One is it points out a generational conversation. I think I shared with you in the podcast that when I was a resident in New York City, I was actually a member of it. So as part of the New York City union, and we looked at situations within our own hospital and said that we got to do something about this. It was a situation where we were getting, $5 meal card, for being on call 10 times a month. This is pre-workout, right? And a hamburger in the cafeteria cost $8. And there was no call room. So I mean, I walked up many hills backwards both times. And younger people will sit there and say, "Oh my God, here come all those stories." But those are conditions in which we try to do. Now we tried to do formal union among private house staff back when I was a resident, but failed because there was no ability for us to really understand how to create it. The SEIU was very new to the world of residents, and at the end of the day, too. Generationally, I think we felt that we were going to take 10 calls a month, bust ourselves open, and then, maybe as a chief, make it easier. That was the rite of passage. I think generationally now, I think residents are of a different mindset. And if you listen to the Northwestern residents who just recently unionized, I think a week and a half ago, their spokespeople are talking about the fact that we are underpaid. We're working too long hours. And when you break down the hourly rate to what residents do, they're absolutely underpaid. And so they're asking for an increase. Now, why do they so choose to unionize? Because of the same circumstances that any union arises, because they felt they're getting beat up and they had no outlet for any success, no outlet to make any change. Here's what I see as the problem. If we look in the future, as this begins to take hold, we don't see many physician unions. There's a handful. Alina in Minnesota, there was one in Providence, and I think Oregon or Washington State, where a group of physicians unionized because they felt the same conditions were troublesome. The problem that I see is that now you have generationally residents who are graduating with a union mindset. And unless something changes, that mindset is going to go into the future position. I don't see this going backwards. I see this getting bigger. And the only way to counter this at the end of the day is to give meaning to this idea of collective bargaining, this meaning to the idea from physicians. And again, the larger picture of trying to figure out a way to stick together, right? Because I don't know if unions are the right way to go. I think the unions are it's a mechanism, with a cudgel at the end, right? Its only mechanism to create direct action is to have a work stoppage. From a professional standpoint, we have to ask ourselves that question: is work stoppage appropriate? Kaiser is in the middle, I think, unless they finish, 6 or 7 day work. 40,000, healthcare providers went on strike in this last week in Northern and Southern California. 40,000. I don't know what the heck they're doing right out there. You look at countries like Korea. It's my Korean colleagues. The residents went on strike in Korea for 2 years. They didn't show up for 2 years. It was unbelievable. They only recently started showing. And the reason for that, because the government had imposed a requirement that we're going to increase the number of residency slots in a country that has the lowest birth rate in the world. And they wanted to hire and bring in more pediatricians and more obstetricians. And the residents who were looking at this say, you're going to saturate the market because they're not going to go to the peds. They're going to the plastic surgery that I want to do. Right. And so this created a gigantic conundrum. And in that country, their Korean Medical Association actually has legal standing as a bargaining unit. And they went on strike. I couldn't believe it. It's been almost 2 years. They finally just went back to work. I don't know what they forgot over 2 years, but they got to, they're running to us. My general sense, and I go off on a little bit of a tangent, but my general sense is that, unions are definitely here to stay. I think it behooves all of us to try to figure out if there is an alternative to that. And I think one of the greatest alternatives to that is for us to stick together in ways that are outside around labor, right? Because the union is not about advocacy, right? A union won't go out and start talking about increasing or linking Medicare payment to the inflationary index. Their unions are not out there at the front line talking about the vaccine schedule, right? They're in many ways focused purely on the labor market. And I think recognizing that, my hope is that it drives more people to groups like us, because at the end of the day, you have to ask that question: if we're not here.
It's a great way to close. And once again, Dr. Suk, thank you so much for such an engaging conversation. Really appreciate everything that you do.
Excellent. Don't broadcast this, because I probably said things I might get in trouble.
Oh, well, it'll just be on our YouTube channel. But at this time, I just want to thank Dr. Suk in particular for giving us of his time and his expertise. And thank you to all of you for joining us for this edition of Conversations at HMA. We want to hear from you, so please feel free to email us at info@hawaiimedicalassociation.org. For those here in the room, we will move on to our meal and libations, and the conversation will continue. Mahalo.